Good afternoon, everybody. My name is Nicole Weinberg. It's so nice to see you all here today. We're going to have a lively discussion about cardiovascular disease. So I'm a cardiologist. I am one of the founding members of Have a Heart, Save a Heart charity, which is a heart disease awareness charity. We put on medical meetings throughout the year to really raise awareness for the leading cause of death, which is women's heart disease. Our meetings do culminate in February, where we have a big Women's Heart Symposium. This year we celebrated our 10th year, and it was recognized by the city of Santa Monica, so they have now proclaimed February as Women's Heart Disease Awareness Month, so we are extremely proud. But today we have a bit more of an intimate group. We're all gathered here today to hopefully start to target some of these more nitty-gritty issues so that we can really start to raise awareness for heart health. We want to have a chat that's a bit more personal. We want to get to some of the root of the questions that you all have for us, because heart disease affects 1 in 4 women. And so we understand that this is not a small issue. It affects more women than the next leading causes of death, to the second, third, and fourth leading cause of death combined. And so heart disease is certainly a very big deal. So it's really important that we get the message out. We also, as a charity, work to raise awareness through some research protocols. We also are identifying some patients in our patient assistance program. So we're really trying to get the message out to so many different people and to really raise awareness for women's heart health. Our chat today is on longevity. So we want to live long, healthy lives, and we feel we can do that if we're aware of our cardiovascular health. So it's interesting, if you look at the statistics in the United States, women's life expectancy is about 77 years old. So we want to live perhaps longer than that, but we want to live very full lives. We want to be healthy, and we don't want to be restricted by the things that we want to do because we have a variety of different comorbid conditions that keep us down. So that is some of the things that we're going to talk about today with these 2 experts that we have. We have experts in cardiology and neurology. We feel the brain-heart connection is extremely important. And if you look at the disease processes that afflict patients as they age, they end up falling into these 2 categories by and large. So without further ado, I'd like to introduce our 2 experts. We have Dr. Alexandra LaJoy and Dr. Marissa Chang. If you guys could both introduce yourselves.
Sure. So I'm a non-invasive cardiologist like Nicole. I work at Pacific Heart Institute with her in Santa Monica here.
Hi, I'm Dr. Marissa Chang. I'm a neurologist in Santa Monica. Southern California girl. Went to USC for undergrad and did my neurology training at UCLA, and then practice here in Santa Monica in private practice.
So as you can see, we've got a really fabulous panel. We're going to have a very elevated scientific discussion, and you guys are going to be giving us some questions, but I'll just start off since it's the top of the hour. So if a patient comes to you guys and says, you know, I have either risk factors for cardiovascular brain health diseases, or I have a bad family history and I just want to make sure that I'm going to live longer, have great longevity, what are some of the things that you do as part of your evaluation?
Yeah, so I love when patients come to me with that question because preventative cardiology works really well. So coming in ahead of time asking how to avoid things is great. It depends on a lot of different factors what we'll do, depending on the patient's age, their family history, other medical problems they have. But basic screening has been proven to make a big difference in preventing heart attacks. So for young patients, cholesterol screening, asking about lifestyle habits, smoking, diet, exercise. Once they get to a certain age, you know, between 40 and 55, depending on their other risk factors, doing a coronary calcium scan, which has been proven to have tremendous value in preventing heart attacks and determining someone's risk. And then, depending on those results, other specific testing. But the great thing about cardiology is, you know, unfortunately, heart disease is still the #1 cause of death in the United States, but there are different types of heart disease. The vast majority of deaths related to heart disease can easily be prevented, which is a tragedy, but also a great thing. I read recently that the likelihood of an American living to 100 has doubled since 2020, and that's mainly because of prevention of heart attacks, fatal MIs. The sad statistic attached to that is that, well, kind of sad, 1 in 3 people will die with a diagnosis of dementia. So that's where Dr. Chang comes in to help.
Yes. So, I think it's important that not one size fits all, especially when it comes to neurologic health. And we want to live longer, but we also want to live better. And so what we need to do is protect our brain as the heart feeds our brain. And so the same processes that can afflict the heart will also afflict the brain. So as we age, what happens is that our blood vessels harden and they narrow, and gradually over time, plaque builds up. And that plaque is a mixture of fat and cholesterol, and then clots can form there. And then when clots form, the clots can travel up to the brain, and that's what a stroke is. So what we're trying to do is assess people's what are called vascular risk factors. And these are the things as we age that can stiffen the arteries and harden the arteries and promote that plaque buildup. So the things that we want to modulate are high blood pressure, diabetes, smoking, and really protect our heart and protect our brain.
Are there certain tests that you would order right off the bat if somebody said, I really am worried my mother had, a heart attack when she was, young, or my father had a stroke when he was really young? Are there certain tests that you would order right off the bat to evaluate them?
Yeah, definitely. And I think, like Marissa just pointed out, there's a lot of overlap between neurology and cardiology. So if they're old enough, postmenopausal, if they don't have a family history, or premenopausal, if they do have a strong family history of heart disease, the calcium scan that I mentioned to screen for plaque, a basic cholesterol panel, and something that we've learned a lot more about in the last few years, a blood marker called lipoprotein A, which is an inherited form of cholesterol that it ties to a higher risk of heart disease and I believe stroke as well.
Yes.
So order other tests.
Yeah, and then if we want to take a look at the main blood vessels supplying the heart, those are the carotid arteries, which are the 2 main blood flow arteries to the heart. So there's something called a carotid ultrasound, which is totally non-invasive, that's done as an outpatient, where we ultrasound the main blood vessels feeding up to the heart to see if there is any of that plaquing and cholesterol building up there.
So one of the things that I hear from patients when they come in, is that they're worried about doing some testing because they're worried about radiation risks. So are there radiation risks associated with some of the tests you're describing?
There are. So a coronary calcium scan is a CT scan. It's very low radiation compared to a full chest CT because we're not looking for detail, we're looking for calcium in the heart, which there shouldn't be, and if there is, it's plaque, and you can pick that up with relatively low radiation. So that's why we don't do it in every patient at any age, because it is radiation exposure, but once your risk goes up enough that you may have plaque, we do that scan, and we don't do it frequently. Most patients, it's once in their lifetime. Some patients will repeat it at a 5-year mark. So you are correct, there is that risk benefit, but it's overall relatively low radiation.
The nice thing about a carotid ultrasound is it's 0 radiation. It's just ultrasound waves. We ultrasound pregnant women, we ultrasound babies all the time. In terms of CAT scans of the brain, we don't routinely recommend screening CAT scans of the brain, as that does involve radiation. There are scans called MRI scans, which do not involve radiation, and those are magnets, and those are very safe to get. The only contraindication for those would be if you had any metal in your body, such as a pacemaker. And there is something called an MRA as well, which stands for magnetic resonance angiography, where we can actually take a look at the blood vessels in your brain and your neck as well.
So let's say that we get some of those tests back and they do show some of this plaque buildup that you've talked about, or some of the atherosclerosis. So when do you start to treat that, and how would you go about treating something like that?
Excellent question. So in the brain, you want to treat this early. So ideally, you want to catch this before it even becomes an issue. And this is where the preventative aspect comes into hand. So really, you want to manage your cholesterol, manage your LDL, manage your diabetes, and really get those vascular risk factors and your high blood pressure under control. If we do find that there is a significant amount of narrowing or a significant amount of plaquing in the arteries, then there are procedures that can be performed to sort of roto-rooter and open up the blood vessels for us. So there's different procedures such as a carotid endarterectomy where a surgeon will go in and sort of scoop out the plaque that's in there. And there's different stents, which are little metal springs that can be placed to open up the arteries, and different sort of roto-rooter procedures that we can do to open up the arteries and prevent something from completely clogging or breaking off and causing a stroke or other neurologic issues.
Yeah. I mean, for cardiology, those preventative things we want to do before any plaque is there, the exercise, the maintaining good blood pressure, healthy diet. Every patient is different, and there are a lot of different factors that go into our decision, but once you have plaque on that calcium scan, we know you have plaque, and we can't tell exactly how severe it is from that type of test alone. Sometimes there's indication to do further testing and find out more information, but most plaque can cause a heart attack, no matter where it is or even how severe it is at presentation. So that's when I recommend statins, or for patients who can't tolerate them, other lipid-lowering therapies.
So one of the things that I hear about when patients come in and they have atherosclerosis that's been documented, they like to know, are there other things that could cause the plaque to have deposited in their arteries besides cholesterol? Because sometimes their cholesterol numbers will be low. So it is interesting, because you mentioned lipoprotein little a and some blood sugar markers are those things that we worry about as it relates to plaque being deposited. And are there other things that we should be alerted to in terms of their medical history, other disease processes, radiation, things like that?
Absolutely, and that's why everyone should have a really good preventative cardiac exam, even if it's not with a cardiologist, with some provider, because we know patients can have excellent cholesterol and do all of the right things and have heart attacks. And part of the reason that these talks started were because there is so much overlap between other systems and other conditions. We know that rheumatologic conditions, especially rheumatoid arthritis, you have a much higher risk of having a vascular event. With certain inflammatory conditions. Pretty much name your system. If there's inflammation somewhere else in the body, it can increase your risk.
Absolutely. I think sort of the newest research is showing how important managing inflammation is. So whether that's in our joints, whether that's in our gut, whether that's in our heart and our brain, the new studies are showing that inflammation is a main risk factor for both heart and brain health.
So I think the concept of longevity and some of these longevity specialists are starting to exist. I have patients come in a lot and they say, oh, my friend went to a longevity specialist and they prescribed a cocktail of different medications. Are there certain things that you believe people should definitely be on? Are there things that people should definitely not be on? Or are there things that you feel like they get teased out along the way?
So I think everything needs to be personalized. I don't think there's a one size fits all. So literally the supplement industry is an over $100 billion industry. And you walk through, the aisle of any drugstore, you'll end up with a bag of $500 worth of supplements that have been told that it will prevent cancer and heart disease and everything that ails you. So to me, a supplement is a supplement, and just that. It's not a substitute for a nutritious, well-balanced diet. And a vast majority of the world cannot afford supplements and do not take supplements and live long, full lives. So to me, I really want to follow the data and I want to follow the studies to see exactly which are in double-blinded, placebo-controlled trials actually helping people. So when you look at the data, especially for women, I think that there's two important supplements for our bone health and for inflammation, and those are calcium and vitamin D. So as we age, we naturally become osteoporotic and we lose some of our bone density. And so I think calcium and vitamin D are good supplements to take as we age. In terms of the other supplements, there have been some interesting studies about fish oil for brain health. So fish oil is what our body naturally needs to form myelin, which is the covering around the neurons of the brain. Fish oil has also been shown to help for inflammation. So in terms of supplements, the ones that I generally recommend for my patients are fish oil, calcium and vitamin D, especially for women. And then some very interesting studies are emerging about the gut microbiome and the gut health. And in our body, most of our neurotransmitters are actually produced in our gut. And so really we want to have those good probiotics, prebiotics to promote that healthy gut health. Now, most patients can do that with a healthy, normal, well-balanced diet. But if you're noticing some gastrointestinal issues, that's where supplementing with yogurt or a pre and probiotic, I think, can help with the gut microbiome and the gut health. And for me, those are really the only supplements that I routinely counsel my patients about and recommend.
Yeah, I agree with everything you said. And just to emphasize the importance of individualization, because fish oil is one of those things that even in cardiology, if you have coronary disease and your triglyceride levels are even mildly elevated, there is a lot of benefit. There's also been research that very high doses of certain fish oils can cause an arrhythmia called atrial fibrillation, which is associated with dementia. So it's all that balance and making sure you're on the right regimen for you. In terms of longevity specialists, one of the questions I get a lot from patients is about metformin, which I think it's a medication we've had for a long time. There's a lot of good research for it in the right patient. You know, patients who have incredibly low blood sugar maybe isn't the best thing for them, hasn't been researched as much in those patients. But I think the thought with that is because your brain is, you're gonna have to correct me, like 2% of your body weight, but does 20% of your metabolism. And so it's thought that maybe there's some link between dementia and glucose metabolism. We see these associations between less dementia in patients who follow a Mediterranean diet. And so I think that's the thought, but I don't know that there's much data to really support that yet. But again, there are a lot of good benefits for that medication. So I don't stop patients from being on it if they have other reasons. And then just to add on it's the supplement in what you eat. One question I've gotten a few times recently is about a food called duckweed, which I still have not tried, but I guess it's commonly eaten in parts of Southeast Asia. That research out of Harvard and Ben Gurion showed a lower risk of dementia and vascular problems in patients who ate this. And it's thought to be because of the polyphenols, which are in a lot of foods in the healthy Mediterranean diet. And so I have patients asking if they should take polyphenol supplements, which I don't know even exactly what those are, but the research showed that it was the diet that benefited the eating it, not so much the supplement. So
correct. And I think when you read these small isolated studies, we have to realize correlation does not mean causation, right? So we have to really take a step back and not just jump on the bandwagon and be taking, 30 different supplements every day, because really it's not a substitute for a well-balanced, nutritious diet, low in simple carbohydrates, high in fiber, green leafy vegetables, etc.
Yeah, I think it is really interesting. It really kind of drives home the point that, like, you are a full body. Like, you're not just an organ system. And so how your heart affects your brain, how your gut affects your heart, how your blood sugars affect it all. I mean, it really kind of drives home the point that all of these things are really critically important. And I think that's one of the reasons why we really like these conversations, because I think you may go to your cardiology office with a laser focus on your blood pressure or your cholesterol, but having an understanding about how it all interrelates is really helpful. So one of the disease processes that we touched on that does affect heart and brain health very significantly is atrial fibrillation. And it's something that we're finding more and more people are diagnosed with now because we have many more monitors to be able to capture people's rhythm issues. So blessings associated with, I think, a lot of these AI technologies that we can check at home and Apple Watches that I see in the audience, we're picking up more arrhythmias than we ever did before. So how does that relate to our longevity and our cardiovascular and brain health?
So normally, a heart is supposed to beat at a normal rhythm and it's supposed to empty. And so what happens during atrial fibrillation is instead of that nice, consistent heartbeat, the heart quivers a little bit. And when the heart quivers a little bit, blood clots can form at the bottom of the heart. And then the blood clot can form and then break off and travel to the brain and cause a stroke. So one of the main risk factors for developing a stroke is this abnormal heartbeat called atrial fibrillation. And a lot of times people don't even know that they're in the rhythm. So they don't even feel a quiver or feel a warning. And the first sign can be a stroke. So one of the main risk factors for stroke is atrial fibrillation, and that's really where we need our cardiologist to come and help either control the rhythm, or if we're not able to control the rhythm, then we typically start the patient on some blood thinners to thin the blood to make the blood less likely to clot and cause a stroke.
Yeah, and I think going back to your point about the whole body, even patients who don't have known strokes with atrial fibrillation are 13% higher likelihood of having dementia than people without it. And so it's probably, beyond just strokes or maybe missed strokes. There are other processes that increase your risk of both. We know sleep disorders can cause atrial fibrillation, and poor sleep quality is absolutely affiliated with heart disease risk and dementia. So it's a big system that we're still learning about.
Yeah, and with very powerful drugs that also have other interrelationships. And so I think it's a really important risk factor to identify and then treat so that we can hopefully combat that as a significant risk of impairing people's longevity. I feel sometimes when patients come to me, they say, I'm not so afraid of having a heart attack, but I'm really afraid of having a stroke. So figure out what we have to do to prevent that. So I think that that's a really big thing. We have a question from the audience. Women don't necessarily experience similar symptoms of heart attacks as our male counterparts. So what are the things that we should be paying attention to, maybe not only for a heart attack, but also for a stroke? What are some of the symptoms that we would want to be alerted to?
Yeah, there are definitely different symptoms that can be more common in women. The other factor before I answer that, though, is women are more likely to ignore symptoms. So they may be the same as their male counterparts, but they keep doing whatever they're doing, taking care of other people or whatever that may be. And so the first thing is listen to your body. And if something doesn't feel right, go see a doctor and make sure that doctor listens to you and looks into whatever it is. We think of the classic elephant sitting on my chest, which women can have that pressure in your chest. Women are a little bit more likely than men to have the other symptoms like pain in the jaw, the neck, back of the shoulder, arm. It can be just shortness of breath that wasn't there before. Things that were easy before, you have to stop and catch your breath now. It can be nausea. Sometimes it can be fatigue, just feeling really exhausted doing activities that usually don't exhaust you.
For stroke, really it's any acute, quick change in your neurologic status. So any weakness on a part of your body that shows up, any numbness, tingling, drooping, slurred speech, difficulty understanding or producing language, please don't wait. Call 911. Don't feel embarrassed about it. Don't try to sleep it off. Really, when it comes to stroke, time is brain. And so we want to catch these fast because there are things that can be done in a hospital setting to break up blood clots, to retrieve blood clots, and really improve neurologic outcomes.
Some of the other questions from the audience have to do with how women's hearts different from our male counterparts. So kind of along the same lines, do women deposit plaque the same way? Do they have plaque rupture that's similar? Do they have different hormone changes that affect their cardiovascular and brain cerebrovascular system different than their male counterparts?
Yeah. I could talk about this probably for a full hour and not address it all, but yes, they are different. They're of course very similar, but there are big differences. As far as plaque buildup, we tend to see more of that postmenopausally, so related to hormone changes. Like a lot of areas of women's health, we are behind in research. There's more being done now than there has been in the past, but most of the research in cardiology, over the last several decades was done in men. So thankfully we're learning more about that now, but there are differences related to hormones for sure. There's a condition called stress-induced cardiomyopathy or broken heart syndrome, Takotsubo's cardiomyopathy. It has a lot of different names. It is almost exclusively in women when a major stressor, the death of a loved one or something of that similar degree, causes sudden heart failure. It can be severe, it can be life-threatening. It almost always recovers if patients are treated for it, but what's different about a woman's heart and her stress hormones and receptors that causes that? It's fascinating, but we need to learn more. I had one case in fellowship where a man had it, and he had a heart transplant from a female patient. That was really interesting. Yeah.
I think as women, we're one big hormone-producing machines, and all of us women know that our hormones affect our brain. Right? So when you're pregnant, you can feel that sort of mommy brain or that pregnancy brain, or even as you're going through PMS or going through menopause, cognitive issues are very much related to hormones. And so if you look at the studies, about 2/3 of people who have dementia and memory loss are women. And that's not just because we live longer, it also has to do with our hormones. And so some of the emerging studies are showing that women who got their periods earlier and then menstruated for longer have less of a risk of developing Alzheimer's disease. And the thought is that that has to do with having more estrogen and progesterone in your body and in your brain for a longer period of time. And so I think this generation of women, we've been through a lot in terms of what doctors have told us about hormones. So I think most of our moms were on high-dose hormone replacement therapy for their menopause. And then over 20 years ago, a big study came out called the Women's Health Initiative study that showed that women that were on hormones had a slightly higher chance of breast cancer and some cardiovascular events. And so literally—
Those were synthetic hormones they were on though, right?
Correct. So literally almost overnight, there was this huge shift where women were just stopped off of postmenopausal hormone replacement therapy. And that's what it's really been over the past 15, 20 years. And now researchers have seen a correlation in people who have been on hormones do have a slightly lower chance of developing Alzheimer's disease as they age. And so now the conversation is shifting, and we're realizing menopause is not just an on-off button, and women can really suffer with premenopausal symptoms and menopausal symptoms. And to say, no, you're not allowed to have hormones in a lot of situations is cruel, right? So really what we want to do is take a personalized history and figure out, okay, what are your vascular risk factors? What menopausal symptoms are you having? And some of the data is showing that for a short period of time, as women are younger and entering that menopausal stage, there may be indications for a low dose supplement.
Along the lines of dementia that you were mentioning, there's a question from the audience about the link of antidepressants and dementia. So is there any link? Is there anything that we should be aware of?
Great question. So I think first it's important to sort of define some terms just so we're all on the same page. So what exactly is dementia? Dementia is memory loss that's severe enough to affect somebody's normal day-to-day activities of daily living. And so dementia is really just a descriptive term. It's like saying I have a cough, right? And then really what you want to do is you want to figure out, well, what type of dementia is somebody having? And so the most common type of dementia is Alzheimer's type dementia, which accounts for about 70% of dementia. And what Alzheimer's type dementia is it's a buildup of certain abnormal proteins called beta amyloid and tau, and these build up and they form these abnormal plaques in certain parts of the brain, and that leads to an Alzheimer's type dementia. The other 30% of dementia is other causes of dementia. So there's other variants of dementia, as well as what we call vascular dementia. And what vascular dementia is when there's strokes in the brain, and these strokes sort of muck up the connections in the brain and slow down the processing of the brain and cause memory loss. So when it comes to antidepressants and other medications causing dementia, we have to be very careful because, again, correlation does not equate causation. And so there's been a lot of press of, do sleeping pills cause dementia? If I take an Ambien at night when I can't sleep, is that going to make me demented? Or I take an Ativan or a Xanax once in a while, is that going to cause me to become demented? And so what the studies have found is there does seem to be a slight correlation in people over the age of 65 who regularly take medications to help them sleep, whether that's the benzodiazepines or the Ambiens or the Lunesses of the world. But when you tease that out, why were those patients started on that medication, right? Was there a few years as they were entering that pre-dementia stage where they knew something was a little off and they were having some difficulty sleeping and they were feeling anxious, and so their doctor started them on the medications? What we know is that there's mood changes that accompany memory loss and accompany dementia. And so again, just because we see that correlation in the data doesn't necessarily mean that there's the causation there.
Along the same lines, there's a question from the audience about the latest research on Alzheimer's and does it manifest itself differently in men versus women?
Great question. So again, I could talk for a whole hour about this, and this is such an exciting time in dementia and Alzheimer's research and treatment. So when I was training at UCLA, literally the only way you could really tell if somebody had Alzheimer's disease 100% was to unfortunately wait until they passed and then to do an autopsy and take a look at their brain and see if there were these characteristic plaques and tangles in the brain. But just in the past 10 years, there's been really good advancement in diagnosing Alzheimer's disease and diagnosing it early. So the two ways now that are available is there's a special scan called an OmniVid scan, which is similar to a PET scan, but what we do is we inject actually a radioactive tracer to the protein that builds up in the brain called beta amyloid in Alzheimer's disease. So you inject IV this radioactive tracer into the veins, and then you image the brain, and you see if the brain takes up this tracer. And when you look at the studies, it's about 96 to 98% sensitive at picking up these abnormal proteins. Again, with the caveat that it's not 100%, and some people do have genetic amyloid in their brain that isn't going to cause Alzheimer's. So that's one way, is these OmniVid scans. The second way is to do a specialized lumbar puncture, where we actually put a little needle in somebody's back and we draw out the fluid that surrounds the brain and spinal cord, send it to a specialized lab, and they can look under the microscope for these abnormal proteins. There's also some emerging research about looking into people's eyes and looking into the backs of their eyes to see if there's the buildup of these proteins as well. And why does that matter? So the newest research is the FDA has just approved 2 medicines that are available IV that actually have been shown in early stages of Alzheimer's disease to reverse some of the memory loss. And so these literally have just come out in the past couple of years, and they're not perfect, so they are user intensive. So depending on the medicine, it's an IV infusion in your doctor's office every 2 weeks or every 4 weeks. And then there is a chance of complications such as brain swelling and brain bleeding. So serial MRIs have to be performed. And so these aren't perfect medications, and they're difficult to administer medications for a lot of people, but these have been some of the first medications that have been shown to actually gain function in people with diagnosed Alzheimer's disease.
So there are some newer programs now in the area, like brain health, kind of I similarly equate it to like a cardiac rehab. Can we talk about some of the modalities for treatments that are not drug related per se, that are kind of brain health or cardiac rehab help that can, maybe without medication, with exercise therapies or other modalities, try to modify these disease states?
Absolutely. So about 10 years ago, there was a researcher at UCLA, Dr. Dale Bresdalen, and he published this sort of hallmark study in older adults who were showing signs of Alzheimer's disease. And he showed a improvement in their cognitive status with lifestyle modifications. And these lifestyle modifications were intense, but they're doable. And so a lot of these brain health programs in town are really modeling his research to make major lifestyle modifications. So what were his suggestions? So the first is diet. And really it's eliminating those simple carbohydrates and sugars that we all love and crave so much. So it's a Mediterranean diet that's heavy on fiber and green leafy vegetables and healthy lean proteins. The second is sleep. So sleep seems to be this missing piece when it comes to brain health. And sort of the sweet spot in the studies is anywhere between 7 to 8 hours of sleep. And so really, if there's one easy low-hanging fruit that I can tell patients, if there's one thing that we could change, is if you're only getting 5 hours sleep a night, try to really concentrate on that sleep and increase your sleep. The third is exercise. So half an hour of cardiovascular exercise a day is huge. And then the last thing is what we call cognitive engagement. And what that is having that community, having that, you don't need to sit and do an hour of Sudoku every day, right? But what you want is you want to have a good mood. You want to have things to look forward to. You want to have interesting people to talk to and really challenge your brain cognitively.
So interesting, because I feel like some of that overlaps in like more global, cardiac rehab programs that we have in the city. I don't know if you want to speak to some of the benefits of what we get out of a cardiac rehab program after people have.
Yeah, it's the same. It's the exercise. I tell patients, when they ask what's one thing I can do, well, don't smoke, and after that, exercise. It's good for everything. The Mediterranean diet, 100% overlap there. Sleep, and then that social interaction. It's interesting you say that, because when I first came into practice after fellowship, it really struck me that so many of my cardiac rehab patients who had heart surgery or had a heart attack really benefited from the exercise, yes, but even more so, they would talk about the small groups they had with the other patients and that social connection they had that pulled them out of their depression, which is really common after cardiac events. So.
One really good question from the audience is about some of the AI technology that's popped up. I think technology, as well as the land of COVID, kind of was empowering the patient to detect some of these issues on their own and be able to alert their medical team to when there are issues. So I don't know if either one of you want to talk about some of the kind of critical AI technologies that have helped with cardiovascular and brain health.
Yeah, I don't remember the exact statistic of percentage of cases, but I never was a big tech person until probably a few years ago with the Apple Watch EKG. It's pretty good. We're not sponsored, but it's really good at detecting atrial fibrillation. And I've had a handful of patients come in, no symptoms, no idea. And they say, my watch just told me I might have atrial fibrillation, and I should see a doctor. And it's accurate, and that prevents a stroke if you catch it beforehand. The older devices were more of a hassle. You'd be on call and a patient would say, my watch is going off. It says my heart rate's 200 beats per minute, and I'm sitting, and they weren't always accurate. But the latest, and it's not just Apple, there are other good devices out now. The newer devices do work really well, and I think they benefit patients' health.
I think where AI is huge in neurology is in terms of rehab. So our unfortunate friends who have suffered from strokes or paralysis, some of these AI technologies in terms of facilitating communication as well as rehabilitation in terms of getting limbs moving again, spinal cord injury, it's a really awesome time.
I am reading questions that are being submitted to me, but if there's anything in the audience that people want to ask personally, feel free. This is a good moment.
How determinative is it for a gene test to show you that you're not prone to Alzheimer's disease?
Great question. So typically in the commercially available gene tests, such as 23andMe, et cetera, they're testing for a gene called ApoE4. And ApoE4 is a gene that's expressed that when it is expressed does put you at a higher risk of both heart disease and Alzheimer's dementia. And when you look at the studies, about 20% of the world's population possesses this ApoE4 gene, and not 20% have dementia. So it's certainly not a one-to-one correlation at all. But when you look at the studies, it does put you at between a 2 to 3 times higher risk of developing Alzheimer's disease. And so really, again, I see probably a patient a month in my office that got an ApoE4 test done at the cardiologist and comes in and says, oh my gosh, I'm positive, what does this mean for me? And what I say is, look, this is not your genetic destiny by far. There are things that we're going to do. We're going to monitor you a little bit more closely, and we're going to modify all of those risk factors that we spoke about. But by no means is this your genetic destiny at all. There are some very, very rare genes that are not tested for routinely, that in people that have genetically based Alzheimer's disease, where they show Alzheimer's symptoms when they're in their 20s and in their 30s, but those aren't commercially available. So really it's that ApoE4 gene that's readily tested.
AFib, that's the short. Can that be picked up on an EKG?
It can. So an EKG is a rhythm strip done in the office that's 6 seconds. So what your heart rhythm is for that 6 seconds that it's being recorded. And if you're in atrial fibrillation at that moment, yes. The problem is a lot of people go in and out of atrial fibrillation. And so it may only happen after you've had some alcohol, or it may only happen at night when you're having sleep apnea that you don't know about. And those clots can form that cause strokes at any time that AFib happens. And so I think one of the problems with a lot of the tests we do in cardiology is they give a false reassurance because you're good at that moment, but we don't know what's happening at other times. And so yes, if you're in it at that moment, it could. And that's why things like the mobile devices that record continuously or every time you feel a palpitation can be helpful, or monitors that we put on in the office that are big stickers that will monitor you more continuously. And for some of our patients, our mutual patients, where we think there's a high likelihood that atrial fibrillation was the cause of stroke, but we haven't picked it up, we put loop recorders in, which are tiny little devices that go under the skin and record for a couple of years and can notify us.
So we recently just had a question about some of the trials emerging for Alzheimer's disease and some of the challenges associated with some of the new medications that have been approved for Alzheimer's disease. So in the past 2 years, as we spoke about previously, there have been 2 IV medications that have been approved for treatment of early Alzheimer's disease. And these new medications are called monoclonal antibodies. And monoclonal antibodies are a super exciting new class of medicine in neurology and in many facets of medicine. So basically, a monoclonal antibody is a lab-designed sniper molecule that's designed to just go to the one thing that's causing the problem. So when Trump got COVID, he was the first person to get the monoclonal antibody to COVID, and that's where sort of the term monoclonal antibody gained a lot of popularity. But they have these for cancer treatments and for autoimmune diseases and for a lot of other things. So in neurology, they have these two monoclonal antibodies that are designed to go to beta amyloid, the abnormal protein that builds up in the brain, and break it down. And so they are very expensive. So they are tens of thousands of dollars. And if you look at sort of how America is aging, there is a lot of people who have Alzheimer's dementia. So when you look at the studies, if you live to 85, about a third of people at 85 have Alzheimer's disease. And that's a shocking amount of people. And so really the controversy here is, okay, these medicines are there and they're available, and they're really expensive. So how as a society are we going to pay for these medications? How are we going to diagnose these patients early enough? And as we discussed, these treatments are not without their potential downsides, and they are intensive treatment to have a person go to the doctor's office every 2 to 4 weeks to get regular scans. And so that's really where some of the controversy lies.
Will an aspirin a day keep the blood clots away?
That's a good question.
So that is a very popular saying, and many generations of doctors just gave every patient an aspirin a day. And again, this is where the individualization of healthcare and having those conversations with your doctors are so important, because even though it's a baby aspirin that's available at the 99-cent store, it's not a completely benign medicine. So anybody who takes an aspirin will tell you, when I hit my hand or my cat scratches me, I get a bruise. And what that's showing is that it's thinning the blood. And so when you thin the blood, I can't pick where that blood is thinned. So if you have an ulcer and you have a bleed in your stomach, that bleed is going to bleed more. If you fall and you conk your head and you have a little brain ooze, that brain bleed's going to bleed more. And so routinely for my young patients that do not have elevated cardiovascular risk factors, I don't recommend an aspirin a day.
And I'm just going to follow that with the key thing she said, who don't have elevated cardiovascular risk factors. I don't know if it was last November or 2 Novembers ago, one of the popular newspapers had a headline that aspirin's bad. People shouldn't be taking aspirin. And so many of our patients just stopped aspirin because it made sense. And there are a lot of cardiac conditions, even for people who haven't had a heart attack per se, where they do benefit from an aspirin still. And some people it can be dangerous to stop. So it's individualized. Talk to your doctor before starting or stopping anything.
And it's also important to know an aspirin is an antiplatelet therapy, and then there are anticoagulant therapies that we use for different conditions like atrial fibrillation and blood clots. So again, the individualized approach and speaking with your medical practitioner about who should be on these drugs and what you're actually treating.
Dr. Nicole, I have a question. With respect to both the use of cannabis for pain control and also this new trend in using diabetes medication to lose weight, what is the effect, both short-term contraindications with current medication that a patient may be taking, and thirdly, long-term effects for both the experts? That's a handful, but there's the question.
Should we start with cannabis first?
Sure, we'll start with the hard one first. I'm going to start this by saying the research is still being done. There's a lot I don't know, we don't know as healthcare providers, and it's very individual. So I think a lot of healthcare providers, including myself, would agree that some medications for pain just don't work, or frankly are not as safe as using cannabis for certain conditions. So it's what's going to keep you functioning and improve your quality of life. And there are different forms of cannabis that can be used. there's been research showing a higher risk of heart attack in patients who use marijuana. The details of that have not been teased out well in a study. I think a lot of providers, including myself, think that smoking anything is just a bad idea. And so smoking certain things versus using other forms that may be safer. For just pure recreational use, I'm going to say no. That there are definite harms with that. But from a therapeutic standpoint, I think there are definitely some reasons certain patients should be using them, and they may be safer than alternatives. Roundabout answer.
Yep. I mean, I think what's so hard as a physician advising patients about cannabis use is, as doctors, we want data, and we want to know sort of, is one puff of marijuana is 2 puffs the exact same double as 1 puff? There's so many different types. Is it what % THC versus what % CBD? Is it in an edible form? Is it in a tincture form? Is it in an inhaled form? And to be honest, we just don't have that data. And so my gut feeling is, I think there is a role for cannabis, especially in pain and sleep and mood. But I just don't have enough data to recommend what percentage of each component, how to take it, to really give you a good scientific explanation. My gut feeling is I don't think we should be inhaling things if we don't have to inhale them. But I mean, I think that's really where we need that objective, reproducible data.
And how about the hot diabetes medications? What do you guys thought?
I think there definitely is a role for these new medications. I have prescribed them for my patients who are diabetic and obese, especially if they're morbidly obese, because we know the risks from being morbidly obese are very high. If you look at the actual data for those studies, both patients were given lifestyle interventions, but that extreme success, which I should have reviewed this, I think it was like a 16% weight loss was seen on the medication. Those patients also were enrolled in diet restriction of 500 calories less a day than they were eating and intensive exercise programs. So it's not just the medication. I think it is a useful tool for those patients who need help. We know there is much more than just what you're eating and what you're doing for exercise for your body. There are so many factors that affect your body weight. And they work well at controlling diabetes and helping with weight loss. Do I prescribe it to patients who are not diabetic or are not obese? I don't have enough data myself to feel comfortable for that, because we know there are risks. There's risks of a type of thyroid cancer that is rare in humans, very rare in humans, but in rat studies, there was a higher risk of that cancer with these medications. We haven't seen a case that I know of yet in humans, but there's that theoretical risk. There's maybe an association with accelerated diabetic retinopathy, which we can screen for. If you're seeing your ophthalmologist, that's okay. And we just don't have the long-term data yet. So for the right patient, I think it's a good thing. But
I agree. I think this is a super exciting time in obesity management. And as somebody who's struggled with my weight most of my adult life, I know that removing this stigma and saying, wow, we have these medications now like Ozempic and Mounjaro, and what these medicines do is they basically mimic the hormone in your brain, the peptide in your brain that tells you that you're full. And so really these have been revolutionary in terms of weight management for people who really struggled. And I think now is a really exciting time to sort of change how we think about obesity. And what we know is that obesity comes with a lot of other complications. People who are obese have a higher risk of high blood pressure and of diabetes and inflammation. And we saw this a lot with COVID, where the people who were obese had a much higher risk of mortality with COVID. And so I certainly think that in people who are obese, who have diabetes, I think that these medicines are so exciting and play a huge role. I don't think if you want to lose a vanity 5 pounds before a big event, I don't think you should be injecting yourself with these medicines. But I think for the patients who really do have obesity and diabetes, these are going to be a game changer.
Believe it or not, we are 3 minutes to 1 o'clock. And so that hour flew by, but I thought just if we can just take a minute each and just do some closing remarks, just to kind of wrap up this wonderful first time Hearthside chat. It's been so wonderful. So I don't know if you want to.
I just want to say thank you for listening and thank you for showing an interest.
Yeah, thank you. These were great questions. This was fun. And my one takeaway for all this, for your brain and your heart, exercise.
Yeah. And I just want to thank you all for coming out. I want to thank the host from the bottom of our hearts, that just to have this group together and feel this energy in the room, that we all not only want to make ourselves better, but hopefully make our communities better. You are all like your own little president of the company, and hopefully you'll go out and take this information and spread some good scientific information to the people that you love and your communities. And if there's any questions or more research that we need to bring to the table to hopefully continue this educational journey, we can all do it together, and these will continue to grow, and we will get this good information out to our community. So it is so much appreciated that you spent time with us. Anybody who's logged on to our YouTube channel, we're thrilled to have you here. We're hoping to get more and more data into our library so that we can continue to combat the leading cause of death, which is heart disease. And tune in next time for our second Hearthside chat. Thank you so much.